please let us know. You can access it via the Teams channel, and we'll also circulate the slides and any kind of links or things that are discussed in the chat. So don't worry about taking notes unless you would like to. We do have time for Q&A at the end, but if you've got any questions throughout the session, please just post them in the chat. And if possible, we'll address them as we go through, or we'll come back to them at that Q&A time. We're also going to be doing some polls. So if you've joined any of these before, you would have seen that. So using the Microsoft polls function. So just when they do pop up, if you're happy just to respond and click your answer, and you can see other people's answers as well. Here's just a quick view of our agenda today. So we'll start with overview of engineering and estates facilities involvement, go into those understanding engineering requirements, and then you'll hear a couple of case studies. And as I mentioned, we've got that time for Q&A. As you would have seen in the comms, and if you've come to any of these webinars before, so NHS England, NHS Elect, and UCL Partners are running these webinars. So you've got representatives from those three teams on here. And then we're also joined by Lindsay, who's a sustainability project lead at UCLH, and then Max, who's an energy manager at Cambridge University Hospitals. And as I mentioned, they'll be sharing their case studies a little bit later, and you'll also get the chance to ask them any questions you have. We are now on our 8th webinar of the series. You can see that there's been a combination of live webinars, but also some pre-recorded. And you can access the recording and also the slides to any of the previous ones via the Teams channel that you would have been added to. So if you're interested, please do check them out. We also have a couple of general drop-in sessions. So these are really open, informal sessions. If you've got any questions or challenges that come up related to nitrous oxide mitigation, please feel free to attend. We had one last week already, and we've got one coming up on the 20th of March. So what I'm going to do now is just a real quick poll. So just give me 1 second. Beauty of multiple screens. So you should just see it pop up in a second, and it's just understanding what stage you would say your organisation is currently at a nitrous oxide waste reduction work, and it's just really to get a feel for who's in the room and an understanding. It's all anonymous, and if you're kind of between stages, just pick the stage you would say best represents. Hopefully people are seeing it. It makes sense. Great. I see someone has clicked already. Great. Seeing some answers come in. Excellent. So we're seeing that some people are a little bit earlier on in their journey, and some people are further on at the end from an implementation perspective. Great. So I'll just leave it 1 minute.
Now I'm talking.
Great, thank you to those that have responded. So again, it should have just popped up in front of you if you're happy to just share where you would say your trust is at in your nitrous oxide reduction work. Okay, thank you everyone. So just in terms of the objective for today, so it's around equipping NHS teams with a clear understanding of the engineering requirements for nitrous oxide waste reduction. And we'll be covering decommissioning piped gas systems, implementing portable cylinder solutions, and identifying and mitigating leaks. And just one more poll from me. So this, what we like to do is just a bit of a pre and a post evaluation to see whether we've met the objective, as I just said, of the session. So you'll just see it appear in a second. So it's just understanding how you would currently rate your understanding of engineering requirement for nitrous oxide waste reduction. And again, it's totally anonymous. It's just to get a feel for how you would see your understanding, and then we will do a post-fun at the end of the session as well. So if you're just happy to pick the option which best aligns to where you feel you're at. Great. So we've actually at the moment got people at either fair or very good, interestingly. Okay. Okay, so that will stay open. So if you haven't had a chance to respond, it will stay open in the chat. And as I said, we will repeat it at the end as well. And again, if you've attended any of our webinars before, you will just understand and have heard that we are going along this nitrous oxide waste reduction roadmap, and the webinars have been mapped along here. And we'd also like to say that excitedly the toolkit, the nitrous oxide waste reduction toolkit, is now available for download. I'm actually just going to hand over to Claudia and Katie to give a little bit of detail about it.
Thank you, Ella. So yeah, the toolkit has been in development for the last about a year, and I think a couple of people on the call have contributed, so thank you very much for that. And all of these sessions, these webinars, are shaped around the guidance that we have in the toolkit. So the toolkit is kind of a written version of all of the elements that we will be discussing. And I guess it looks like there's some people who have either excellent or very good knowledge of engineering requirements in this session, which is probably actually more than us, to be honest, just to start that. But I guess something that we can share is that we've talked to trusts, about 60 stakeholders from all over the country, in developing this toolkit and these materials. And so our guidance and advice on engineering requirements might be a little bit different to what you've heard about in the past and what the previous kind of approach has been. And so maybe this will uncover some kind of new ways of thinking about this now that we're in the process of many more trusts kind of being on board and having done this work. The whole process of reducing waste might require some different engineering approaches than maybe that you've heard before. So hopefully, even for those who have excellent or very good knowledge of the engineering requirements, we are going to bring something new both through this session and the toolkit, which is linked in the chat now. So thank you very much. And Katie's just going to share the slides for us to go through and launch into the session. So hopefully, if you have been on our other sessions, you'll know that this whole process is about aligning our medical gas pipeline, aligning our medical gas supply of nitrous oxide or Internox, aka gas and air, aka nitrous oxide oxygen mixture, aligning that supply to the clinical use. So at the moment, what we see is that most places are buying a lot more than what they actually use. And so the whole purpose of nitrous oxide waste reduction work is to align and make that balanced. So that is kind of the key part of the project, which is that during stage. So you make sure you're buying what you actually use rather than much more than you use, and getting rid of the waste. And then there's also a third part, which is making sure that you maintain and continue to have that alignment of supply and use. So that's kind of also got a lot of engineering requirements and elements to it. So we're going to go through how engineering fits into that throughout this session. And I'm just getting some feedback, so I'm just going to mute. Sorry about that. So hopefully you've also possibly seen the key combination of actions that we kind of have shared throughout these sessions, and this is what the foundational kind of advice from the toolkit is in order to supply your gas to clinical use, align your gas to clinical use, you need to look at how much people are using clinically. And if an area is not using any gas clinically, then it's really simple. You need to decommission the medical gas pipeline system, and you don't need to replace it with anything because no one needs the gas. if the clinical area has a low use of the gas, which we've got some kind of guidance and templates around what low use means, but this is often in anesthesia, in ED, in endoscopy, all of those kind of areas, then we suggest moving from a medical gas pipeline to a portable cylinder system. And with that, you're really like reducing the amount of gas that you're buying and aligning it to clinical use. And you decommission the medical gas pipeline system after that. And then finally, we've got high clinical use areas. So these areas like maternity and maybe dentistry, pediatric dentistry, where a medical gas pipeline system feels like it is required. And in these cases, there might be a combination of actions, and there might be several different approaches to aligning your supply to clinical use, which could include moving to a portable gas system. It could include fixing a lot of leaks. It could include removing your demand valves from the wall. There's a lot of actions, and all of this has kind of gone through in previous sessions. So feel free to go and access the recordings of those if you need to. But what we're going to go through today is the next, like the kind of key engineering parts. So throughout all of this process, engineers are required. They're a really key player in this work. They're normally on your medical gas committee, hopefully, and know these systems inside and out. And I'm sure there's some engineers on the call who know a lot more about what that looks like than me. But these are the key engineering requirements. So the first is they might help us to understand the discrepancy between clinical use and supply. And they might do that through several different ways that we'll go into in a bit. The second part is switching to portable cylinder systems. So engineers can help to support us set up the storage locations. We might have medical technicians or engineers, equipment engineers who help us to configure things right and help us make sure things are connected well. And then the third part is the decommissioning of the medical gas pipeline system. So you need an authorized person for that, who is an engineer, and they have their own kind of protocols that they need to follow for that. And that's quite a key part of reducing waste. A fourth engineering requirement might be their contribution to redesigning a medical gas pipeline system. And finally, often they really help, and engineers are really helpful, and it's part of their job to help identify and fix leaks, including pipes, valves, terminal units, etc. So these are the 5 things that we're going to go into a little bit more detail about throughout this session. Just to kind of preface this with, for the rest of the session and for your information, engineers and medical gas pipelines are kind of overseen by the Health Technical Memorandum, or the HTM 0201, which basically provides essential guidance for medical gas pipeline systems. It covers the design, the installation, and the management of them. It supports the safe and effective system management. And there is actually a new version in development of this. I might be kind of adding something in that no one's been worried about, but a worry that some people have had when we've talked to them is that removing a medical gas pipeline system is a derogation from the HTM. But from talking to NHS England and working really closely with them, it's not. It's if you remove a medical gas pipeline system because it's not clinically needed, that is not going against the HTM. So just to reassure anyone of that it kind of is supported by the HTM. And yeah, the new HTM's in development, and it will be a lot more aligned with the toolkit and aligned with kind of what we've learned from working with everyone, which is essentially that you don't need a medical gas pipeline system for most clinical areas. And where you do, you should really make sure that it's kind of as small and short and maintained as possible, so that you're not getting any extra waste, because that's where a lot of the system waste comes from. And this is just a little bit about kind of where the engineering teams often fit, because I know that there are often clinical teams who are really keen to do this work on nitrous oxide, and they might not know how to access the engineering teams. And we really strongly recommend going to your medical gas committee, and there'll most definitely be an engineer or someone representative of engineers in there. And there's typically also the medical gas supplier. If you've got a PFI, there's often a PFI rep. There'll be your authorised person, or hopefully someone kind of aligned with them, and then normally pharmacy and clinicians involved as well. So just to say that that's quite a key place to engage, and that the engineering team is really essential throughout this whole process. So and we know that they're very busy, so make sure you kind of utilise the forums that they already are part of, and the places that they're already having to attend, rather than anything extra. But equally, we've found it so helpful for people to go and visit their engineers and talk to them and say, hey, look, we're really not using nitrous much at all. Can we please think about removing our pipes? So yeah, that is a bit of an intro. And I'm going to start going into some of those 5 engineering requirements that we talked about. So the first one is understanding our supply compared to clinical use. And I'm sure most of you who know about the nitrous oxide work know this, but the problem with nitrous oxide and with Entonox, we think, is that there's a lot of upstream waste. So you put a bunch of gas into the manifold room down the bottom, the basement, if you see in this picture down the bottom, and by the time it gets to the patient, only about 1 to 20% of the gas that you've purchased has actually reached the patient. And between that big manifold room and the patient, there's so many opportunities for gas to be wasted. And that's often through manifold connections, through unused terminal units, or just through terminal units in general, through isolating valves, potentially through pipeline damage. It is unlikely, but that could be the case. Pipeline connections, pendant connections, maybe in delivery equipment, through the demand valves in the mouthpiece, and often through stock management as well. And what we've found is that all of these different kind of components, they might be tiny little leaks that don't feel material, but when you combine it all together and you combine it with a system that's running 24/7, you get massive amounts of waste. And we all hopefully know that it's really environmentally damaging, but also costs a lot. Well, not too much, to be honest, for nitrous oxide, and that's part of the problem. But nitrous oxide, it's very environmentally damaging. And I mean, we're maintaining these systems that maybe we don't actually need. So that's just a quick recap of where the waste occurs. And that's what we want to try and find out, how much do we actually need? What is the difference between what we're buying and what we're clinically using, so that we can align our supply to be what we need. So the estates and facilities team can help you with a few different approaches. And the first approach is simple data analysis. So often people will come to this problem to find out, how much we're clinically using, how much we're buying, let's do this calculation. And it's a big, big process. And what we've found is actually you don't need to do that. What we've found is you can go to your clinical team and you can say, do you use nitrous? And they might say, no. And then therefore you have an answer of how much you clinically use, and you can compare that to the amount you're buying. Maybe they'll say we use it for 1 patient every week, or we use it for 1 patient every fortnight, or, and basically getting that simple qualitative feed information helps you to figure out the discrepancy between what you're buying and what you're using. And so you can do a simple approach to finding this out. And your estates and facilities team might be convinced by hearing that clinicians don't use it, and there's often a gap. They're not told that no one uses it anymore, and so they're maintaining the system that no one actually really needs. The second approach, if that doesn't work for your trust, if you do need more details, is that you can gather data from other sources. So your pharmacy procurement data, your clinical surveys, and other usage patterns. And that can help build a clear picture without necessarily needing extensive engineering involvement. We've got a webinar about our creating an action plan that we developed, and go and watch that to kind of find out a little bit more about that. Another thing is that communication with estates and engineering teams is really important. It's important to clearly articulate that there is this discrepancy. And we've found it really helpful to frame the discussion being about waste reduction rather than focusing on leaks, because, these teams are doing a really stellar effort at maintaining these medical gas pipelines. And often the leaks could be in equipment rather than the pipeline. And they can kind of hear that the pipeline isn't being well maintained when that's not, the truth of it. So yeah, effective communication and just like making sure you're framing it in a way that is about, what the solution is, and that waste is the problem rather than leaks being the problem. And finally, we've found that one of the most compelling points for estates teams, although sometimes it takes some convincing and some case studies to prove it, is that moving from a medical gas pipeline system to small cylinder supply actually can reduce a lot of work and can create savings for estates teams. Because clinicians are not really using this gas in a lot of areas that much, they find that they're not having to replace a lot of cylinders really frequently, and actually it shifts to being very infrequent and a lot more streamlined of a process. So there's operational benefits for these teams, and that's a part of helping to buy in the estates and engineering teams, and build that case. So the second key engineering requirement is helping teams to switch to a portable cylinder system. So it's not, to be honest, it's not like a key engineering requirement, but you definitely do need your estates team and engineering team involved in this process. So one of the parts might be equipment safety and connectivity. So just making sure that your equipment is all right and safe. And when we talk about engineers, I'm not just meaning the medical gas pipeline engineers. It might also be medical technicians or people who work directly with, anesthetic machines and things like that. So they can really help to make sure everything connects up safely. The second part of switching to a portable cylinder system that engineers can help with is your storage solution. So we hear a lot of people worry about, where are we going to store all of our new cylinders? And again, hopefully from the previous exercise, you'll know that you're not actually going to need that much gas. And so you won't have as many as you maybe perceive because you're used to having the medical gas pipeline. But you will need some storage, and you will need safe storage. And so we've seen some really creative engineering ideas across the country, and a lot of people are using their old manifold spaces to store the smaller cylinders. The third is just general kind of medical gas committee oversight, so making sure that everything's signed off for moving to the portable cylinder system. That is where engineers will be involved. And then finally, updating any infrastructure that is required. So helping to make sure that all of the infrastructure is safely installed and managed. And that is a key part of the engineer's involvement in switching to a portable cylinder system. Now I'm going to hand over to Katie, who's going to talk through kind of one of the big bulky parts of it all, which is the decommissioning part. Katie, over to you.
Great, thanks, Claudia. And hi, everyone. My name's Katie. I'm an implementation manager in the climate team at UCL Partners. And for the last few years previously to this role. I was at King's College Hospital working on the nitrous oxide waste reduction project there. And yeah, just to say up front, I'm not an engineer, but this is the guidance that has been developed with engineers and with people who are integral to this project, and some of our own experiences too. So please do, I think, know that the next few slides are supposed to, that the intent is to give an overview of what the system actions are, for you to be knowledgeable, have that collective understanding of the process, and to go away and have a good conversation with engineers at your trust. Or indeed, if you are an engineer, feel free to add some comments in the chat alongside these slides. But yes, they're top level, and the intention is to bring knowledge to you, so you're able to go away and have good conversations with those experts who do sit in your trust, who are able to action the decommissioning of a medical gas pipeline system, and to run tests of various different kinds on the medical gas pipeline system, which we're going to talk through as well. And I've got multiple screens up trying to navigate these, so sorry if there's a little delay in me moving along my slides. But yes, just to start, when do you decommission a medical gas pipeline system? And I'm sure some of you in the room have already done this, but typically when an area of low use, for example, theatres, anaesthetic theatres, have switched to a portable cylinder system. It's well embedded. It's now the new way, and it's the only way of really using nitrous oxide in that setting. And it's been agreed, and it's in practice and in place. And that enables the estates engineers and the teams to complete the process, which is decommissioning the medical gas pipeline system. So it's no longer available, and it's no longer a supply mechanism for that particular area. So that means, and again, this has come from talking to various different trusts and understanding what that really means in practice. It doesn't mean the physical removal of the infrastructure. It's about safely shutting down and isolating the system. So no need to pull pipes out of walls. And this can be either a complete shutdown, or indeed, if there is a manifold that's serving multiple clinical areas and only some of those clinical areas are now using portable cylinder systems, specific branches of that medical gas pipeline system can be shut down. So it can be total, can be the entirety of that system fed by that one manifold, or indeed it can be a series of specific branches of that system. So partial or complete. And as I mentioned just at the top there, physical removal of pipework is not required. Is not required for the safe shutting down of a medical gas pipeline system, in order to not be disruptive, right, to all the clinical areas and add additional costs where they're not needed. So there's a top level list here of the considerations that the specific engineering considerations that should be thought about when decommissioning a medical gas pipeline system. And the first is alarms. So alarms that occur, that exist at various different places within the medical gas pipeline system. So at the manifold side and in the clinical areas, the area valve service units, or AVSUs as sometimes they're called, they need to be identified. You need to know where they are, which can be a task that in unto itself in doing this work, and of course then adjusted to prevent false alarms that might occur when and during or after a decommissioning process. So that's the first thing to be aware of, those alarms, and the authorised persons and authorised engineers in your trust will help to be able to identify those and calibrate them to ensure that they don't sound in the decommissioning. A step-by-step safe shutdown. And the next slide that after this one goes into a little bit more detail of what those steps are for your information, so you get a sense of what some of the activities might be that the decommissioning the medical gas pipeline involves for you to aid your conversations with engineers. And the engineers and the authorised persons who are qualified to carry out this work will, like Claudia mentioned, be well aware of the Health Technical Memorandum guidance and will be following that to do this process. And And then I've mentioned authorised persons just now. An authorised person is a technical term. Authorised persons and authorised engineers will exist at your trust. They're responsible for the day-to-day management of the medical gas pipeline system. So the manifolds, the pipework, the valves, the terminal units, the alarm systems, as I mentioned just now. And like I said, their standard practice is to be aware of and to follow the safety guidelines. So that's the HTMs, that's also ISO international standards as well, to manage medical gas pipeline systems. They're the right people to talk to get this off the ground. And of course, the fifth consideration is medical equipment adjustment and calibration. There are alarms on anaesthetic machines and other clinical equipment, and they might need to be adjusted to when the nitrous oxide supply is coming via a portable cylinder system as opposed to a medical gas pipeline system. There are often teams within trusts, from my own experience and speaking to other trusts, medical technicians and others who are able to support with that. So like Claudia mentioned, engineers not only sitting in estates but across clinical areas too, who are able to avoid alarm sounding due to the removal of the pipe nitrous oxide supply. And I think there's a link there. I think Angeline's just put it in the chat. Brilliant. Thank you, Angeline, around a technical update for the nitrous oxide systems. A useful and on that slide there, you can see on the right-hand side is an example of a capped off terminal unit. So at the point of clinical use, well, in the decommissioning of a medical gas pipeline system, one of the first things to do is usually to cap off that terminal unit to ensure that no clinicians continue to rely on that system once a portable system or indeed no system, if they don't use the gas, is in place. So these are those steps that I mentioned just now around a safe shutdown of a medical gas pipeline system. Not to worry that they look long and complicated, and it's probably not the best design of a slide, but they are all detailed in the action plan, the key action checklist tool, which there's a link at the bottom there that I think will probably be appearing in the chat shortly. That's one of our recommended supporting components that goes alongside the toolkit. There's 10 of them, and this is a key action checklist. It's a long list of all the possible actions that have been collated from all of the different projects run so far at trusts. I'd say it's exhaustive, but every trust is different, and there might be some steps that trusts take that others don't. But this section is all detailed under the decommissioning of a medical gas pipeline system. So you've got those list of actions in there. And this is really to help guide you and help you understand what those steps are that those authorised persons will be taking in your trust, and ensure that those who are involved in the project at the clinical side are able to communicate to the rest of the team what's happening and when and why. So there's sort of 4 parts to this. I think 5 actually. I've created 5 parts to this. The first is planning. So this will be in the Medical Gas Committee. This will be a multidisciplinary decision based on whether or not the medical gas pipeline system is going to be decommissioned, based on, of course, the transition to portable supply or no supply, or indeed the optimization of a medical gas pipeline. So as I mentioned at the top, isolating a specific branch rather than the whole manifolds, things like that. Conducting the risk assessment and decommissioning according to the HTM for estates to do. And then those actions here, I think there's 1, 2, 3, 4, 5, 6, 7 or so actions that the authorised persons and engineers will take to. The first is, of course, to put those unit plugs and all the gas outlets starting clinically. I think that's the key thing to note, is that the best practice is obviously to start clinically to make sure that nobody is using any kind of medical gas pipeline supply anymore, and capping it off is the best way to ensure that that's not happening before, of course, you cut the supply. And then you'll see here it gets quite complicated, and I mentioned I'm not an engineer, so I'm not going to read all of these in detail, but you know where to find them. And then communicating changes, fundamental. Once this is in place, to let clinicians and areas know that this is what's happening. And then after that, several trusts have done this in phases. So I think it really depends on the project that you're running. And If you're doing it all in one go, this may not be a consideration, but if you are going manifold by manifold or clinical area by clinical area, there may be a case where there are partially full cylinders, size G cylinders from the manifold now not needed on that manifold, and you're able to then go and reuse those, rotate that stock to another manifold that is still in use at that given moment, and not have to order, perhaps do an order freeze on the account that's serving that particular manifold, and use those size Gs instead, just to try and mitigate as much waste as possible from the act of decommissioning. And then, of course, updating. So estates taking responsibility for updating the scheme of the pipeline where there is one and where there isn't one anymore because the manifold's been decommissioned, and removing any equipment and informing the medical gas supplier. So in terms of challenges, trusts have found two main challenges when it comes to decommissioning a medical gas pipeline. One of which is timing, and the timing process can be quite tricky to get right. It can be quite hard to line up estates resource. Capacity is really limited, and especially, as I mentioned, if you're doing a project all in one go, that will require then a quite significant amount of time to go and decommission multiple manifolds over a short period of time. And so there are some ways that trusts have tried to mitigate this, and one is running a phased approach. So being able to get a sense from estates what capacity looks like and work with them to plan out how long it would take them to decommission a manifold, how much time upfront notice they would need, and how that might fit in with the plans to roll out portable cylinder system installations to ensure that there's time and sort of ability, and sort of avoid that risk of having a clinical area switch to a portable cylinder system for a long time before the medical gas pipeline system is switched off. So really just trying to work with the estates teams to understand what their timelines are around that. And so there's a few recommendations. One is communicating early and often. I think the Medical Gas Committee is an excellent opportunity, as estates and engineers are often there to understand what that phasing or what that timing looks like. And I think that another key challenge that has come up in our learning and listening to trusts is where there is a PFI involved, and where the manifold and the management of the manifold and the associated medical gas pipeline system sits within a PFI. And PFI contracts may impose limitations or financial penalties for the alterations of that system. Running a portable cylinder system is unlikely to be affected. So installing let's say a trolley style portable cylinder system in an area is likely to be to implicate anything within a PFI. But of course, when it comes to then taking action on the medical gas pipeline system, there are implications there. So there are a few recommendations that we've pulled together and that are in the toolkit based on learnings from trusts that have navigated this. One is to really understand usage data. So running that survey that Claudia mentioned to understand what usage looks like, and then being able to quantify your potential waste to really try and emphasize the size of the problem, to evidence that there is one and that the action can be taken and that there's responsibility for action to be taken to remove the medical gas pipeline system, especially when the clinical area is no longer reliant on it, spurring the PFI management into action. And timing the decommissioning of the medical gas pipeline system to align with contract renewals, renegotiations, to avoid sometimes a financial impact that might occur. And another thing is to really scrutinise the PFI costs for decommissioning. I think scrutinise the PFI costs for everything, but specifically here in regards to the costs that are being charged for decommissioning. If you have a site, for example, that is part PFI and there are authorised persons and engineers that manage other manifolds, just getting some insights into those costs and what they mean, and making sure, where you can, that just being vigilant around no unnecessary costs. And I wanted to ask a question now, actually. If there is anyone in the room who is navigating or has already navigated the decommissioning of a medical gas pipeline system within a PFI, and and indeed if they have any insights that they'd like to share with anyone else. I suppose there's two questions. One is, has anyone done it? And the second is anyone going to need to do it? Would be keen to hear from either. Max, go ahead.
Hiya. So we did that for PFI, one of our PFI buildings, decommissioning the manifolds, but the caveat was that all the medical gases services were still, maintained by our trust. So it was kind of a simple process. But even to be honest, I can't see why it should be a challenge, even if that was maintained by the facility services of the PFI, because that's one fewer service for them to run. So actually, that should save them money in the long term. So yes, basically they might make you pay for the cost of decommissioning, the actual decommissioning of the manifold, which is usually like a day's work of KH Medical of a medical gas company for this. But that's it. They shouldn't have any more cost to it, because that's simple as this. Yeah, that would be my opinion.
Thanks, Max. That's really helpful. And I mean, I completely agree, and I think that's from my experience when working with the PFI who maintain the medical gas pipeline system. I think a big part of the upfront work has been to really try and clarify and expose the problem, and then from there, generally there's receptivity to do something about it. But I think maybe slightly differently to perhaps others, there is and I know that we speak a lot about not needing to collect data, especially where there's low or no use, but simply asking clinicians, getting that qualitative data for the clinical areas that are served by a PFI manifold, comparing that to the volumes that go into that manifold, can really help PFI colleagues to understand the size of the potential problem and leakage that is occurring across that system, and working with them to either fix that or to remove the manifold when it's no longer required for those clinical areas.
Yes.
So moving on to the redesigning of a medical gas pipeline system. So that can happen when there is, I suppose there's sort of two scenarios that I can think of. One is where the medical gas pipeline system has been agreed to be retained in a form. So that might be to shorten the piping to make it smaller. There might also be cases where there is an update, etc. So there will be potentially moments in a medical gas committee or in your conversations or in your project where you're discussing the redesigning of a medical gas pipeline system, as well as the decommissioning of one, depending on the context and the decisions that your trust make that's right for them. So there are 5 elements to this here, and there is specific engineering involvement across all of these. But as I mentioned just now, the medical gas committee is usually plays a central role in the hospital design decisions. So, for example, if you're speaking for anecdotally, if there's a case where you're doing a lot of work to decommission a medical gas pipeline system and to convert a clinical area to portables, and then you find out that there's a new manifold going into another area, perhaps serving theatres, simply because it's happening at the same time as your project, and there's not been the ability to communicate the work going on to align clinical supply to clinical use. So then there's an opportunity to obviously have a conversation about redesigning that system, or indeed not having that system at all. And that's what several trusts have done, I think, has noticed at the right moment where there's an opportunity to have a conversation with those who are designing the system and to really ask if it is needed. But if it is needed, and it's needed to be redesigned and optimized, there are some things that need to happen. And one is that there is like I think I just covered, really assessing clinical necessity and really asking yourselves if it aligns to clinical need. The other is ensuring a sizing and location. So is it as close to the clinical area as it could possibly be, to really try and mitigate the amount of piping, because as Claudia mentioned at the top, leaking occurs across the medical gas pipeline system, and it can occur in the bends of the pipeline. So really ensuring that it's not too big, and it isn't exacerbating the opportunity for leaks to be occurring across large amounts of connections. And that leads us into that third point there about avoiding oversized manifold spaces, avoiding excess connections and cylinders, as they can increase the amount of waste that occurs. The pressure requirements as well to drive the gas through the components is another consideration and requirement in this. And designing the manifolds with shorter pipe distances to the point of care to reduce the likelihood of leaks. These are all considerations that can go into when you're having conversations with your medical gas committee or others about redesigning a medical gas pipeline system, only when the clinical decision has been made to retain it for valid reasons. The next section, we're going to focus on identifying and fixing leaks, principally across the medical gas pipeline system. And there's been a pretty important shift in thinking here. Claudia mentioned it just before. So before the toolkit was published, before the recommendations in the toolkit were gathered and now available, lots of projects and lots of the insights, and it's all been based on the insights of the many projects where the work has been done, have used leak testing as a primary way to quantify waste in the system. So running a leak test, and then understanding what the manifold volumes were, how much is being bought, and then being able to understand how much is being used, how much is being plugged into the manifold, and the difference between those being waste. But because there's so much evidence now around how much the sheer volumes of waste that occur in the medical gas pipeline systems, the toolkit recommends a different approach based on clinical use. So rather than spending time and resources on leak testing up front, the toolkit suggests going straight to a portable cylinder supply where clinical use is low, simply because that's a better system, that's better aligned to clinical use, and decommissioning any manifolds that serve those areas. And of course, for areas of no use as well, goes without saying. And then for monitoring improvements, we recommend using the Greener NHS dashboard, or indeed the procurement records that come through from the suppliers to help you understand how much gas you're continuing to buy on a monthly basis. And that is a little bit more detailed than the Greener NHS dashboard, because it shows you each hospital site and each account that you have with that particular supplier. So going back to leak tests. Leak tests, they are still valid. They very much do have a place, specifically when medical gas pipeline systems trusts intend to keep those, or when, going back to the PFI conversation, when there might be an opportunity to reveal waste levels to help with buy-in, and helping to know the size of the problem, and that might in turn inform the solution that you decide to take. For example, if you discover that your medical gas pipeline system is incredibly leaky, and there's implications there for costs and fixing, it might inform your decision to install a different type of supply instead, whatever is the right decision. So there's two different types of leak tests. One is a system-wide leak identification test, and the other is more location-specific. And within those two categories, there are several different types of leak test that you can do. So within those different categories, you've got your system-wide leak identification. There's two main tests that are recommended. The toolkit recommends as a good approach. One is a pressure test, so a system pressure test with the system isolated. So that's all the cylinders that sit on the manifold taken off, unplugged, and all of the clinical equipment that might be plugged in at the clinical point of view side also unplugged. So a completely isolated system running a pressure test. And there's another option that has been explored and tested out in Australia, and there's actually a link there at the bottom of this screen, which I think hopefully will go into the chat, that gives more information about both of those, but also about weighing cylinders. And that doesn't require necessarily isolation. That requires the weighing of one large cylinder that sits on a manifold. So you basically take other cylinders off that particular bank, and you have just one cylinder on that bank. And there's two different ways you can run that test. You can run it when that cylinder is when that system is being used. So you're able to measure that. You can run a calculation to determine the weight decrease of the cylinder and work out how much gas that is, and compare that to how much the anaesthetic machine. So I'm talking specifically for nitrous oxide in a theatre setting or in any setting where you're able to get that usage data. That's the first option, that you can use this weighing cylinder, so you can compare how much is going into that system from that one cylinder that you're weighing and you're seeing decrease over time, and then taking away from that total the amount that's been used on the clinical side, and then you've got your waste. Another option is when that system isn't being used at all, you can run that same test and really understand how much waste is happening through that entire system. Because it's not being used, any decrease you see in that cylinder weight implies that there is waste running through that system. Obviously, it depends on the ability for you to run a test when the system isn't being used. That's really challenging in areas of high use, but it has been done. Several trusts have done it, and it involves ensuring that there is a portable cylinder system in place, an alternative backup in place for you to then not be reliant on the medical gas pipeline system for a number of hours for you to run either a pressure test or a rain test. And then there are other types of location specific tests. So these are the portable nitrous oxide detectors. These are wearable. I don't know if anyone has one. They might have seen one. You can kind of put it a strap over your shoulder. They are able to work out leak detection, but also occupational exposure. So they work out the parts per million of nitrous oxide over a time-weighted average. So you're able to understand. So if you leave it in one location, it might be useful to identify leaks. And if you carry it around with you, it's generally used to calculate exposure over time for that particular clinician. They do require a calibration though, but they are practical obviously for accessible areas or the areas where people can actually go and be. There are bubble tests. You may have seen spray bottles in the manifold rooms at your trust that can be used to spray the connections at the manifold to understand if they're leaking, where bubbles will appear if that's the case. That again, that's really only helpful in accessible areas where the piping is accessible, I should say, where the pipe is exposed and accessible. Obviously in concealed areas, it's nigh impossible to run that test. And it's good for a quick check of accessible joints and connections. And then there's also an ultrasound acoustic signal test, and that can detect leaks through sound patterns, and it works for all medical gases. And the idea is that it provides an early warning detection. It's a more expensive option, and it does require expert interpretation of the data and the results that come through that system, but has been found to be useful in some trusts for preventative maintenance. So to say that really all of these methods, they have their place. There are rationales and reasons to do each of them, depending on what you want, what kind of information that you want to find out. And of course, the availability of resource, either to procure these items or to access them. But they're really breaking this into two. One is system-wide assessment, and being those two at the beginning, the pressure test or the weighing, versus targeted specific action for understanding of where leaks may be occurring specifically and or repair, and that tends to be the location specific leak detection tests. There's my mouse gone? Here it is. So a little bit more about pressure tests. Pressure tests are considered a gold standard because they are a regulatory requirement. So they will be something that your authorised persons and your authorised engineers understand the details of. And as I mentioned before, they're a system-wide leak identification method across an entire medical gas pipeline system. used to help understand if leaks are present. You can calculate leaks using a calculation based off how much the pressure is dropping by when you do this test. And the requirement is that it needs to be an isolated system. So, like I mentioned, taking the cylinders off the manifold or turning them off, and turning off or unplugging all of the equipment, that might be used at the point of use clinically. Otherwise, it can lead to false negatives, and that's happened. That happened in my experience and several trusts as well. And I've mentioned again the need to use a portable cylinder system as a backup, because obviously you're isolating the system, so you're not able to use that system in a given moment. That could be challenging if you're thinking about something like nitrous oxide oxygen in maternity, but it can be done, and portable cylinder systems can be used with planning, with talking with the engineers and the clinical teams to put something in place to enable to run this test. And then this slide talks a little bit more about the details of how a pressure test works. I don't think, again, it's to help understand what the engineers and what the authorised persons will do at your trust. Essentially, it's pressurising the system. I'm turning off, isolating the system, and then it's pressurising the system. And then the estates engineers will measure the pressure of the system, and if it drops over a certain amount of time, so if it drops significantly, and there are measures to determine what the significance is in this case, then there is evidence of a leak within the medical gas pipeline system. So just the piping system itself, because everything else has been taken away. It's to test the integrity of the medical gas pipeline system. That's the intention of the pressure test. So lots of technical information on this slide. And this is also in our toolkit. So I think if it's useful, have a read of this, take it away, and show it to engineers that you're working with to run a pressure test, if that's useful. It's to help build a little bit more collective understanding. As I said, I'm not an engineer, so I think it would be disingenuous of me to read through this slide in any more detail, but hopefully it's helpful to understand the basics of how a pressure test runs. And then I'm going to pass over to Claudia now, who's going to just talk a little bit more about the different types of maintenance in these systems. Thanks, Claudia.
Thank you, Katie. So we've talked through kind of all of the different parts that engineers are involved in through that process of moving from a system that is way oversized and a lot of maintenance and a lot of extra cylinders compared to what clinical need is. But we've also recognised that there's going to be some cases where you're still going to need a system. And as hopefully we've kind of got across, that should only be in places where you've got higher clinical use. And even in those areas, you might not even need a medical gas pipeline system. So I guess to kind of round this all up, where there absolutely is a need for a medical gas pipeline system, you're going to need to continue to do some proactive and reactive maintenance. And obviously, the less pipeline that you retain, the less work that this will be, because you won't have as much maintenance to do. And I'm just going to talk through a bit about the proactive and the reactive elements on this. And I'm also going to quickly mention that you also need, if you are having a portable cylinder system, it still requires maintenance in some ways. It just won't be as kind of in depth as a pipeline system. So for proactive maintenance for your medical gas pipeline system, just the next slide, Katie. Thank you. You'll need to make sure you have scheduled component replacements. So there's parts along the pipeline that wear and tear, and they'll have their own they'll have their own guidelines around each part of the system. So make sure that you're getting those components replaced. I think often they're like every 10 years for parts of it. Regular system inspection, so keeping an eye in your manifold room on any chips and nicks in there, and along the pipeline as well, like inspecting if there's any damage. Pressure monitoring, so obviously if there's pressure alarms going off, then you'll need to proactively make sure things are right. Then you've got valve and seal checks. My Kiwi accent really comes out when I say the word check. But valve and seal checks along the pipeline. So again, making sure that the valves and seals are not damaged. Documenting all of your work. So that's really helpful, proactive maintenance, because it makes sure that you know what's happened and where things are at and when you last did things. And then finally, yearly pressure tests. So for your medical gas pipeline system, you need to be making sure you're doing that gold standard test for the integrity of the system. And then for portable cylinder systems, there's some proactive maintenance there too. So on the portable cylinder systems, the O-rings can sometimes they can deteriorate over time and cause more leaks. So check those and make sure that you're replacing them. There's connection points that might get little nicks on them as well. So make sure that you're replacing any connection points as required. Staff training on wear signs. So make sure staff are aware what damage means and looks like, so that it can be replaced if needed. And then finally, scheduled maintenance programs as well. So you need to make sure things are replaced when they are too old. And then hopefully that makes you in a really good place for managing, a continued low volume of nitrous oxide waste. But there might be cases where you need to react and you need to repair. And in this case, you've got a few things that you can do. So the first is having your porters and estates and facilities team aware of how much you're buying and reporting on if there's any like excess activity or damage that they need to repair, and also just really clear reporting lines. So what happens if they spot a change? What happens if it increases? Having that in place is really helpful. A quick response protocol to make sure that things are addressed quickly. Rapid repair of identified leaks. Emergency repair procedures, and then clear reporting pathways, which I kind of already mentioned. So there are going to be cases where you'll notice your gas going up, your gas creeping up again, or bringing in more cylinders, or maybe you've had damage, quite extensive damage, and may need to be reactive maintenance of the pipeline. And that is all of the engineering requirements. And so we are going to invite a couple of our colleagues from trusts who have done this work, Lindsay and Max, just to speak through their kind of experience on the engineering side. So Lindsay, I'll invite you first. Thank you.
Thanks, Claudia. Thanks for having me, guys. Just as a sort of bit of admin, I'm actually on an away day. So the place where we're having our away day has kindly let me use their kitchen to speak to you today. So if there's some background noise, I apologise for that. So I just kind of want to talk around our process at UCLH when it came to decommissioning our nitrous manifolds. We have 4 nitrous manifolds in the trust, and we decommissioned 2 of them last year. When this conversation first started, there was initially quite a disconnect between estates and the clinical teams and the sustainability team. So as a first port of call, we spoke to the estates team, who advised that some leak tests had been done of all of our manifolds, and they were confident that there was no waste because the leak tests had come back to say there was no leakages. However, we weren't convinced that this would be the case, given the data that was coming out from other trusts across the country. So what we did was we got in touch with our pharmacy team to get our procurement data from BOC on how much nitrous we were procuring. And luckily, we had some anaesthetists who are very engaged with sustainability work, who managed to evaluate how much nitrous we were using clinically in the areas in which we use it. And from this data, we highlighted that even though we didn't have any major leakages in the manifolds, in one manifold, we had 97% of the nitrous being wasted. In another, it was 81%. And we took this back to the estates teams, and we let them know, even though we don't have leakages, we still have large amounts of waste. And the reasons for this, it's quite complicated because there's multiple areas of waste when you're delivering gas through a manifold system. So firstly, there's a large amount of over procurement, and this again comes from this disconnect between the sort of pharmacy teams who are ordering the gas for the clinical teams who are using it. So the anaesthetists knew that they weren't using nitrous oxide as regularly anymore, but they hadn't really communicated this to our pharmacy colleagues or to our estates colleagues. So the estates colleagues were just supplying the gas as usual. So when we took this data to our estates colleagues and highlighted that there was wastage, we were asked, well, can we not just simply reduce the supply? Now, the problem was, as we said, don't really use this gas that much anymore. And it was very difficult for the communication to sort of be maintained amongst all three parties. So we decided that in two of the areas, we mapped out every clinical room in which this gas was used. So in one of the buildings, we only used nitrous oxide in one room, but we were supplying the entire building. So there, we assessed the annual clinical usage. It was very small, and probably equivalent to about 1.5 size E cylinders per year. So here, it was felt it was absolutely the right solution to decommission the manifold and switch to one cylinder, mobile manifold cylinder directly connected to the anaesthetic machine. And in the other building, we did pretty much the same thing. We mapped out every clinical area in which we use this gas. This one was a little bit more complicated because we use it in theatres, and there was 8 theatres. But actually, when we spoke to the anaesthetist, we found that we were only really using it in 1 or 2 theatres, and only maybe once every couple of weeks. So again, we felt it was safe just to have mobile cylinders that the clinicians could access and bring to their anaesthetic machines just as and when they use them. Now, one thing I would say is attending the medical gas committee meeting as a project manager. Sorry, I actually should have introduced myself. I'm the sustainability lead for UCLH, so that was my role in this project. So I was responsible for bringing everyone together and facilitating these conversations. So attending the medical gas committee meeting was really useful because everyone was in the right place to have this conversation, and it kind of eliminated any misunderstandings or miscommunications between teams as well. And actually, at this point, we got confirmation from BOC that every cylinder that was returned to them, whether it was full, no matter what, it would be vented to atmosphere. And that was something that I think hadn't really been widely understood by our teams before. So as soon as the estates knew this, they suddenly felt very motivated to begin reducing this waste as well. Now, one thing I would say is our estates colleagues are naturally really risk averse. I mean, at the end of the day, they're maintaining the safe delivery of our buildings in which we operate, and they want to minimize risk as far as possible. So they were really concerned that if we removed this gas, there would be some kind of safety implication for our patients, or that clinicians wouldn't be able to access the gases that they need to provide safe care. So having the clinicians on board and facilitating conversations between our clinical teams and the estates teams was really useful, because it just kind of eliminated any concerns that our estates colleagues had. And I would say that we're very lucky that we have an engineer at UCLH who's dedicated to sustainability projects. And myself and him worked very closely together. And having that close working relationship was, from that you're able to understand the challenges that each of us face, and approach issues with a really sort of well-rounded view. From the safety perspective, but also from that kind of innovative and more efficient delivery, the more efficient way to deliver nitrous oxide. So I'd say, for clinicians or for our sustainability colleagues who are looking to manage this project, your estates colleagues having that really good working relationship is so important, and understanding their point of view as well around the safety elements. And I'd say data is going to be your friend when it comes to building the argument for why we should decommission the manifolds as well. And one last thing I wanted to touch on is ultimately the aim of our project was not necessarily to decommission the manifolds, although that was what we did. The aim of the project was to reduce nitrous oxide waste. So it's about having that conversation and everyone coming from the same point of view, the same understanding. Our overall goal here is to reduce nitrous oxide waste. And in the majority of cases, the best way to do that is to decommission the manifold. But it's also about being open-minded and mindful of the challenges that each individual area will face. So that's everything from me. And yeah, I'd be happy to answer any questions in the chat or in the Q&A.
Thank you so much, Lindsay. Very, very helpful, and I think tied together a lot of what we've shared throughout the session. So thank you. And just handing over to Max. Max, I'm just mindful we've got about 15 minutes left, so I'm sorry to give you just a couple of minutes if that's all right.
No, that's all right. That's all right. I'll try to get into it. So yeah, similar experience to all the other hospital. We've got 3 manifolds on site. We have now decommissioned all 3 of them as of last December. So it's basically one of these jobs where it takes 99% of preparation for only, a couple of days of actual works to decommission the manifolds. So it's a long, strenuous process to get to the actual work, but it is simple. Once you've got all the agreement in place for everyone, it takes a day max to decommission the manifold. It's very simple. You can do it. I mean, it took us 2 days for one of our manifold, but that was a manifold supplying about 40 buildings, so massive manifold. So, but if you're talking about a manifold supplying 1 building, it'll take half a day. Very simple. So I wouldn't worry about this. All of the leak detection, yes, you should do it if you need proof to convince people, but the fact is, if you've got pipe network, you're going to have leaks no matter what. It might be 90%, 91%, 95 or 98, but you will know when you do the leak test, but it will be very high. So if you can skip this step because everyone is convinced, just go for it and decommission it and move to mobile cylinders. That would be my advice. But obviously, I imagine people need to be convinced in every organization, but that's what takes the most time, basically. So yeah, that's pretty much me. That's 2 minutes. So if you've got any questions, I'm happy to answer.
Thank you, Matt.
Don't worry if you didn't get a chance to capture anything down. And a massive thank you.